All right, everyone, thank you all for joining our webinar this evening. This evening's presentation will be given by Dr. David Kugelman, who is a fellowship-trained orthopedic surgeon who specializes in hip and knees. Dr. Kugelman sees patients at Rothman Orthopaedics offices in Media, Glen Mills, and Limerick, Pennsylvania. I know many of you sent in questions ahead of time, but please feel free to enter your questions in the Q&A box at the bottom of the screen during the presentation. Please keep your questions as generic as possible, not too specific to your case. We do have a lot of people logged on here this evening. So please note that we likely won't be able to get to every single question, but I know Dr. Kugelman will do his best to answer as many as possible during the time we have. So thanks again for joining us, and Dr. Kugelman, you can take it from here.
Thanks, Natalie, and thanks everyone for joining us. So my talk will be on healthy knees, the management of knee arthritis, pretty much from the beginning with non-operative management, all the way through surgery and post-operatively. So an outline of this talk, what is the knee? What's knee arthritis? How do we get knee arthritis? And then the bulk of our talk will be on both non-operative and operative management. So for non-operative management, we'll review lifestyle changes, exercise, physical therapy, bracing, medications and injections. And then for operative management, we'll talk about partial knee replacements and total knee replacements. So why is this such a hot topic nowadays? Well, as the world's population continues to grow, people continue to age, and the prevalence of osteoarthritis continues to increase. So at the turn of the millennium's second decade, over 500 million people were living with osteoarthritis, which is pretty much over a 100% increase from the 1990s. And out of all the joints, the shoulder, our hands, hips, ankles, feet, the knees are actually the most common joint affected by osteoarthritis. And there's over 365 million patients living globally with knee arthritis. So why is this a big deal? A lot of our research shows that knee arthritis is actually as disabling, if not more disabling, than chronic kidney disease and congestive heart failure. If you're suffering from arthritis, you know how much this is affecting your life and how much it impacts you on a daily basis. So what is the knee? The knee is a hinge joint, and that makes it more complex than something like our hip, which is just a ball and socket. So the hinge joint, it moves in multiple different directions, and it's made up of three bones: our femur, which is our thigh bone, our tibia, that's our shin bone, and our patella, that's our kneecap. And each of these bones, there's an articular surface, so that's our cartilage. And the cartilage is supposed to glide together, roll over one another with no issues at all. Now, this smooth cartilage, it acts as a cushion during any weight-bearing activity or movement. And cartilage, it doesn't have any pain receptors. It's a natural lubricant. When cartilage is healthy, everything is going great. Now, our knee, besides the cartilage and the bones, we have a lot of ligaments. And if you look in this picture on the right, you can see all the ligaments. So we have the MCL, which is right here. We have the LCL, lateral collateral ligament, right here. We have the ACL, which is in the middle. Also behind is the PCL. And these are ligaments you hear a lot about, football injuries and things like that. And then we also have cushioning. It's the menisci. So the menisci, it adds a little extra support in addition to the cartilage, and it acts as our buffer to our knee. So the meniscus, they're shock absorbers, and it also helps cushion the knee during ambulation. So what's arthritis? Well, arthritis is the loss of cartilage. And basically, when you lose cartilage, you just have something called subchondral bone exposed. And the subchondral bone, it will hit the other subchondral bone. So subchondral bone of the femur will grind on the tibia, or the patella, the kneecap, it will grind on the femur. And that causes a lot of pain. So that's not natural. It's not normal for our body to have bone on bone. And that's what bone on bone arthritis is. So in this image, you look at the picture that says normal joint space, and that's not a real space. That space that we see in between the inside and the outside of the knee, that's actually all cartilage. Cartilage you just cannot see on x-ray. That's why it looks like a clear space. And we diagnose arthritis with x-rays when you look at that picture that says loss of joint space. So when you don't have that space left anymore, that means there's no cartilage left. And that's what we call bone on bone arthritis. and that will cause significant amounts of pain. So, how do you know if you have knee arthritis? Number one, you're going to have pain in your knee. So, this pain, it's more common when you're walking on it, when you're loading your knee with range of motion. You might feel crunching, catching, clicking. Your knee might really ache at the end of the day, especially after a long day of standing on it. Some patients report stiffness. They'll actually report increased pain when they're sitting for a long time and they go to stand up. You may feel instability. This is because arthritis will affect your entire knee joint. So it may cause some issues with the ligaments. Your ligaments may get loose and you may feel like your knee is unstable. That's a very common issue with arthritis. And then decreased motion. It will be more difficult to get that full flexion that you're used to or that full extension. And over time, this will get worse and worse. So, what are the causes of knee arthritis? Well, it's typically a malfunction of the knee. And what happens, whether it's a soft tissue injury, whether it's trauma, fracture, genetics, increased age, something's going on with the knee that will eventually lead to unequal loading of the knee joint. So you may have more pressure in one compartment over the other. And when I say compartments, the knee has three compartments. You have the medial, which is the inside, you have the lateral, which is the outside, and then the patellofemoral, which is the kneecap compartment. So if there's unequal loading in one compartment over the other, that will lead to cartilage degeneration. And if you look at this picture, you can see that there's a normal joint space right here on the outside of the knee. But due to unequal loading, maybe it's a meniscus tear, maybe it's a ligament problem, history of a fracture, or just how our body is in genetics, you'll put more wear on that cartilage will eventually lead to this picture right here. And you see in this picture, there's a lot of areas with mixing cartilage, and then that's the bone on bone that we're talking about. Another common question about arthritis is if we have it in one knee, what's the chance of getting in the other knee? And all our research shows it's pretty good chance, it's about 40% chance of having bilateral knee arthritis. So let's go into non-operative management. The biggest thing that we'll start off with is lifestyle changes. This is pretty much, no medicine, no thrills. It's just about us getting healthy. So one of the biggest risks of development and progression of knee arthritis is having increased stress on the joint. So what's stress? Well, that's increased weight. And 1 pound might not sound like a lot, but 1 pound is actually 4 pounds of pressure on the knee. So there's research that shows if you can lose up to 15 pounds, you may have about a 50% reduction in symptomatic knee arthritis. So even for people that are not overweight, just losing a few pounds will take significant pressure off the knee. And let's say in, our running population, it's actually 1 pound equaling 9 pounds of pressure on the knee. Same thing with stairs. When you walk upstairs, that's about 6 pounds of pressure on the knee. So there's a lot of extra force that comes with extra weight. How do we go about doing this? So I definitely advise patients supervise weight loss plans. You want to be smart about it. Low calorie, low fat diets, high in protein, physical activity, frequent weighing, and then regularly eating breakfast. Those are pretty good ways to lose a few extra pounds. When we talk about physical activity, the best thing to do is low impact. Sometimes it's hard when you're in so much knee pain already, but things that are low impact, such as stationary bike, swimming, and walking, that's the best thing you can do for your knees rather than running or lunging or squatting. So the next step after lifestyle changes, it's exercise and physical therapy. So we briefly exercise. And what that also does, besides losing weight, that will strengthen our muscles and improve our endurance. And when we talk about strengthening the muscles, that's why we prescribe physical therapy. If you strengthen the muscles around the knee joint, you're actually going to take pressure off those compartments that I spoke about earlier. So if you strengthen the inside muscles of your knee, on your thigh, your quads, the outside muscle of your knee, the quads, that's going to all lead to a better balanced knee. And physical therapy is definitely very beneficial with doing that. So some studies have actually showed that the magnitude of improvement with any sort of exercise for knee arthritis, it's actually the same as taking non-steroidal anti-inflammatory drugs. And then in a recent review looking at all different types of exercise for knee arthritis, so aquatic exercise, water aerobics, things like that, it actually leads to reductions in the knee pain, while yoga, that will lead to decreased joint stiffness. And both these exercises, they improve function and patient quality of life. So it's new things we're getting our patients involved into. Mechanical devices. So I have a lot of people ask me, what about knee sleeves? There's a million different knee sleeves you might see in a physician's office or on Amazon, Walmart, Target, even CVS. So there's inconclusive evidence on this. Some of the studies show it works, some show it doesn't work. So I definitely think it's worth a shot, and I leave it up to the patient. The most common knee sleeve that I prescribe is something like this. It's a neoprene knee sleeve, and how that can help contribute to decreased pain. It's actually from heat produced from the sleeve, and that will cause alleviation of symptoms. It will also have enhanced proprioception of your knee joint. In addition to proprioception benefits, they'll also improve your posture and your gait, how you're walking. So proprioception, that's our ability to sense where we are in space and time. And if you have a knee sleeve on, it will make the knee tighter because as I said, arthritis, it can make your ligaments weaker and your knee feel looser. So this will make it more compact and you might put less pressure on your knee joint. Other things are these unloader braces. So sometimes I'll see patients that have arthritis solely on the inside of their knee, as you can see in this picture right here, or solely on the outside of their knee. And what we can do for this is prescribe an unloader brace, and that will pretty much try to correct your knee alignment, therefore to help take pressure off the compartment that's assuming all the pressure thus far. So those can help as well. Heel wedges, some research shows this will help as well take pressure off a certain compartment if only the inside or the outside of your knee are effective. But I'm prescribing these much less than both the unloader braces and the knee sleeves. So after that, we start talking about medication, oral and topical medications. Non-steroid anti-inflammatories and Tylenol are the two most supportive drugs that you can take for knee arthritis. So a lot of our research, it points to taking two extra strength Tylenol, so 1 gram, that's when you have therapeutic effects, and then Advil. You can take about 600 every 6 to 8 hours. And a common question, do you have to space this out? Do you take it together? So it's two different drugs, two different mechanisms of action. So you can actually take both of these together. No narcotics. So when this fails, people talk about opioids, tramadol, oxycodone. So I'll never prescribe anything like that. As you know, we're in an opioid epidemic, and there's a lot of bad things that can come from these drugs. So we'll never prescribe that. Obviously, after surgery, we do prescribe that because it is increased pain at the beginning during the recovery process. But our American Academy of Orthopedic Surgeons does not recommend any narcotics for knee arthritis. Also, as far as chondroitin, glucosamine, all these different vitamins and pills you can get from, once again, CVS, Costco, any local store, there's also inconclusive evidence for these to work. So I don't recommend those as either. Voltaren gel, this actually does work wonders. It's a non-steroid anti-inflammatory medication you can rub on your knee. It's over the counter. You can get it at the local pharmacy. This, along with lidocaine patches, those are not a bad idea as well, both over the counter. Injections. So after the medication stop, we talk about injections, and there's many different types of injections. Steroid injections are the most common ones you'll talk about, you'll hear about, and they provide moderate relief, usually short term. On average, I would say anywhere from 6 weeks to 3 months for the first injection. You hear about PRP. This actually is not covered by insurance, and that's because there's limited evidence on it. It's still kind of new in the knee arthritis game. So we had to do more research on this to see if PRP is really improving symptoms and leading to long-term effects. And then HA injections. So these are actually the gel injections. So our academy, they actually recently recommend against these injections There's a lot of conflicting evidence. However, I will still recommend these injections to patients if they failed steroid injections and they're either non-operative candidates or where they're still trying to, prolong their time before a knee replacement. It is worth a shot. It's a minimal downside. The steroid injections, that's my most common go-to. And I tell everyone the first injection is going to work the best. It's going to give you pain relief for the longest amount of time. You're going to feel good. The second injection will probably work pretty good too. However, it starts working less and less the more injections you get and the more your body gets used to it. So I really want people to reserve these for when you're at a 7, 8, 9 out of 10 pain, or if you have a big trip coming up, if you have a wedding, a big family event, because you should use them sparingly as they stop working up until the point where they pretty much may work for a few days, if not longer. The one thing with steroid injections for a lot of patients who are diabetic, it can increase your blood sugar. So I do tell all my diabetic patients if I give them an injection, they should closely monitor their blood sugars for at least 1 week after the injection. And any issues, I'll have them call me. If it's real high, we'll send them to, urgent care. But you got to really, really see what your glucose is looking like and adjust your insulin regimen for these injections. Next, when all else has failed, we start talking about operative management. So this is pretty much, the last resort. There's both partial knee replacements and total knee replacements. And you want to exhaust non-operative management first because this is a surgery. That being said, people are very, very happy after partial and total knee replacements for knee osteoarthritis. So what's a partial knee replacement? Right here, we see in this picture, it's not the whole knee being replaced, it's just one compartment. Once again, we spoke about how there's three compartments of the knee, the inside, the outside, and the kneecap compartment. And you can perform a partial knee replacement for any of these compartments. And what that does, it actually preserves the rest of your ligaments of your knee to make it feel like a more natural knee. So the indications for this are actually pretty much only if you have the disease in one compartment or if you have most of the disease in one compartment with minimal changes in the other compartments. So at 15 years after a partial knee replacement, 81% of patients still have just their partial knee replacement. That means that 19% of patients at 15 years will go on to have an arthritis in either, their outside compartment, if they had a partial knee for the inside compartment, or their kneecap compartment. So, if you have arthritis in another compartment after the partial knee replacement, that's an indication to convert it for total knee replacement. So because of this and because of the possible progression of arthritis, partial knee replacements, I always counsel my patients who get these. I always say, it works great. You should just know there is an increased revision risk compared to a total knee replacement. And the reason for that is if you have a total knee replacement, you can't get arthritis anywhere in the knee. It's essentially cured at that point. But with a partial knee replacement, you still have 2 out of 3 areas that can still get arthritis. Another big benefit, however, of partial knee replacements, besides keeping your ligaments and having it feel like a natural knee, there are less complications compared to a total knee replacement. It's not as big of a surgery, it's not as long of a recovery, and overall, patients are pretty happy with this as long as the right indications are there. Next, total knee replacement. And this is, the most popular type of replacement we do for the knee, and this is replacing at least the outside and the inside of the knee, so the medial and lateral compartment. And then often we replace the kneecap compartment as well. And what that is, you see here, we have femoral component that's made out of different alloys of metal. The tibial component, same thing, made out of metal. And then in the middle, you have this piece of plastic. It's a fancy name for plastic called polyethylene. And, it's not like the plastic you have in a cup or straws, but this will last much, much longer periods of time. So post-operatively, I tell my patients the first 2 weeks to relax. I really don't want anyone doing much activity, kind of treat it as a vacation that you deserve for a long time. So sit on the couch, watch Netflix, almost treat it like a tonsillectomy. Eat ice cream. I really don't want you doing much. And the reason for this is new research has showed if you're doing too much activity at the beginning, if you're going to physical therapy from day one and really working at that knee, there's going to be more inflammation. There's going to be more swelling. We really want that knee for the swelling to get down. I have you elevating your knee. All of the range of motion will come at a later date, but the first 2 weeks, I can't stress enough how much I want you to relax. After that, you see me in the office. We start physical therapy, at home exercises. We work on strengthening, we work on range of motion. At 6 weeks, you're about 60 to 70% recovered. So you're feeling pretty good at 6 weeks, but you're not fully there yet. There's still a lot of gains to be had. But at 3 months, you're about 75 to 90% recovered. For people that have very labor intensive jobs, usually I'll say you're out of your job for about 10 weeks to 3 months. For people who can work at home or sit on a desk, I often have patients working from home a week after, or you can go to your office 2 or 3 weeks after. So it's variable. It all depends on your occupation. And then you'll still make progress for up to 1 year. So at 1 year, that's when you're going to be 100% recovered. Your muscles will be fully strengthened. There shouldn't be any more swelling. So it's a long process, but by 3 months, you're feeling pretty good. So activities to do after knee replacements. Nowadays, we're doing these more often in very active individuals, very healthy patients who really want to get out, moving around, get back to their sporting activities. So once again, low impact is the best you can do. You don't want to put too much stress on this knee joint because it still is metal and plastic. That being said, I recommend against high impact, such as running. Do I have patients that run after a knee replacement? Yes. Are they fine? Yes. But theoretically, and you can see in this picture at the bottom, we're really concerned about two things mainly with high impact activities. That's loosening. The knee can become loose if there's too much pressure applied to it over and over and over again, or for that plastic wear, that polyethylene wear, because increased metal on plastic, and if you keep pounding that, it could get worn down. So the best things you can do, walking, cycling, swimming, yoga, golf, pickleball is a big thing now. All those are fine. Can you run? I don't recommend it, but do people run? Yes. So it is possible. Then here's a slide. It's comparing the two main surgical treatments, partial knee replacement versus a total knee replacement. And I like this slide a lot because it goes over the pros and cons of each. And this is a conversation that we have before the operating room when I see you in the office. If you're a candidate for either a partial, a total, or both, we'll go over these pros and cons. And starting with a partial knee replacement, the pros, it's less invasive. It's a smaller surgery. We're only taking out one part of your knee and putting in metal in that one part. It preserves the cartilage and bone in the rest of your knee. You have more normal knee kinematics. That means your knee is acting more like a hinge joint that we spoke about earlier because you have your ligaments. Less complications. Once again, is a smaller surgery, so there's less issues. Quicker rehab. And then it's an easier revision surgery if needed. You only have to take out part of the knee, and a revision surgery is a redo surgery. What's the cons of the partial knee replacement? It's a specialized procedure. People have to be trained in this procedure in order to do it. It does have a higher revision rate that we spoke about, or excuse me, that we spoke about earlier. So once again, if you have a partial knee replacement for the inside of your knee, like this patient here, if we look at the outside of the knee, it still looks good, but this can develop arthritis over time, and a revision would be performed if that's the case of the progression of osteoarthritis. Then a total knee. What's the pros of a total knee compared to a partial? It's well established. We've been doing this for over 50 years. It's much less specialized. It's much more common. A lot of people, in the community, they're more used to doing total knee replacements than partial knee replacements. So if you don't have access to specialized adult reconstructive surgeons, this is definitely an option for you. It does have a better survival rate, meaning it will last a longer period of time because, once again, this cures the arthritis in the entire knee, and you can't have progression of arthritis in any other compartments. What's the cons? Compared to a partial knee replacement, it is more invasive. There is a slower rehab. You have a little bit more restriction of activity. And as far as complications, they're higher. There is a slightly higher mortality rate that comes with any given surgery. So we actually did a research study a few months ago where we basically gave Apple Watches to patients who had total knees and partial knee replacements. And it was interesting to find that at 6 weeks, the partial knee replacements, they were doing much more activity, a bigger step count, they had more balance. But at 3 months, it kind of evened out. So, there is a quicker recovery, but at a year, it's pretty much equal to your recovery. And even at 3 months, it's pretty close. Complications. So this is a part I'll always counsel patients on before surgery, and you should definitely know that these are major surgeries. Hip replacement and knee replacement are two big surgeries, and the benefits need to outweigh the risks in order to go through to these surgeries. So there's complications such as clots, infection, instability, bleeding issues. All these risks come with surgery. However, we optimize you before surgery. We make sure that you have the best chance of having a good outcome. And then all orthopedic surgeons here, we work together with our medical colleagues to make sure you're fully optimized and you're on the right postoperative rehab and protocol. So, in conclusion, there's two ways to treat knee arthritis. We always start with non-operative management and starting at the basics, lifestyle changes, weight loss, exercise, physical therapy, medication. And when that fails, we start talking about injections. After all this, when you're in a lot of pain and things aren't working anymore, then that's when surgery is an option. And you have partial knee replacement versus a total knee replacement. Both are great options, and people are very happy with both of these procedures. So thank you very much. And now we had a bunch of questions, so I'll start answering some of these questions. Okay. So the first question I have here, are there any other issues that develop as a result of knee osteoarthritis? In my case, chondromalacia patella. So that's a great question. So once again, this leads to different loading of the knee joint, abnormal loading. So chondromalacia patella, it's not a full onset knee arthritis. However, there is some abnormal loading that will affect the cartilage, and there's different treatment options for something like this. If it's only certain areas, there's cartilage restoration procedures. There's some sport procedures you can do for this. And then also, as far as the reconstructive procedures, you have patellofemoral arthroplasty. So that's a good question. And a similar question right after that was, can cartilage be regrown? So if I knew the answer to that, I would be a very rich person. People are trying to do that for years and years and years, and we can't figure it out. There's PRP research that's inconclusive. There's stem cell research that's inconclusive. So as of now, cartilage can't be regrown, unfortunately. There's some sport procedures, it's chondrocyte implantation that are starting to show some okay results, but there's very strict indications for something like that. It's really just very local, small cartilage defects. As far as arthritis, unfortunately, the only procedure that will work for that is either a partial or a total knee replacement. If I can walk for an hour or two with little pain at the end of the day, should I do prophylactic treatment before it goes worse? So, another great question. And this is a common conversation I have in the office all the time. You only get a knee replacement once you really need a knee replacement. And before that, we do try to prevent progression. So if you're still able to walk really well and you do have some early signs of arthritis, there's two things that are known to slow progression. One's weight loss, because as I said earlier, it will take pressure off the knee joint. Every pound's at least 4 pounds off the knee, and that will slow down progression significantly. And the other thing is exercise and physical therapy. If we strengthen our knee muscles, if we take pressure off the joint through strong quadriceps, whether it's through physical therapy, going to the gym, getting out, moving around, walking, that will also help. So those are the two prophylactic measures: exercise slash physical therapy and weight loss. And those are unfortunately the only two things that work. However, when they're implemented early, they work very well. So we do try to catch arthritis early and implement it as early as possible. Do you recommend knee replacement for valgus or knock knee? Great question. So 10% of knee arthritis is valgus. And what that means is that instead of having bowed knees, which is 90% of knee arthritis, and bowed knees affect the inside compartment of the knee mostly, knock knees or valgus knee arthritis, that will affect the outside compartment. That's where the forces are applied. And a knee replacement does cure valgus knee arthritis as well. We do use different techniques in the operating room. It's still a knee replacement. You can still have a partial knee replacement if it's only the outside compartment. But we do use different techniques so that we focus more on the outside of the knee rather than the inside of the knee. So it does work the same. The outcomes are the same for both valgus or knocked knee and varus, which is bow knee. So then we have questions talking about patellofemoral ligament instability. So patients have patellofemoral ligament instability, and that's if your kneecap, if that shifts around, you may have torn a ligament when you were younger, or just be the maybe the morphology of your knee. And that abnormal loading of the knee joint, that will lead to kneecap arthritis. Once again, the best things to do for that is strengthening our muscles. And going off that, we have another question. If stronger leg muscles are beneficial, then why are squats discouraged? So that's a great question. So squats just put a ton of pressure on the knee, and it's only discouraged if you already have bad knee arthritis. If you're in the early stages and we're still doing strengthening, then squats would be okay because obviously that works out your complete lower body, your back, your glutes. They're really good for you, but it does put a significant amount of pressure on the knee. So if we already have knee arthritis, it might not be the best because A, it's going to be very painful, and B, it can put significant weight on the knee that can further damage our cartilage. Does the sleeve help when the kneecap shifts a little? So yeah, that's a great question. So if you do have kneecap instability or patellofemoral instability, there are braces that are called patella stabilizing orthotics, so a PSL brace. And what that does, that keeps the knee in the same place. It keeps the kneecap from moving, from shifting, from sliding around. And patients with isolated kneecap arthritis, especially if it's due to patellofemoral instability, those braces are another thing in our toolbox that can really help out the knee. If you had osteopenia or osteoarthritis, how will that affect a total knee replacement? And continuing into that question, how does it affect cementless or cemented total knee replacement? So this is an excellent question. Osteopenia, osteoporosis, this is when our bone mineral density is lower. And there's two types of knee replacements. So there's cementless knee replacements and there's cemented knee replacements. Cementless knee replacements, that is when you have high quality bone that's not osteopenic or not osteoporotic, and it has the good potential for bony ingrowth. So what that means is that the knee replacement actually becomes part of your bone. So the bone will form around a cementless knee replacement, and that's how our fixation occurs, versus a cemented knee replacement. In a cemented knee replacement, this uses cement to act as a grout in order to hold the knee together. So if you kind of think about it almost like the cement between your tiles at home, it's really just holding the knee in there. And that's pretty much the gold standard. That's how knee replacements first, were introduced, and this is still the most common way to perform a knee replacement. So if a patient is osteopenic or is osteoporotic, the safer bet is to do a cemented knee replacement. And the outcomes are actually the same for both of them. However, if you do a cementless knee replacement, so no cement, and you don't have great bone quality, two things can happen. Either you have a higher chance of breaking the bone, or you have a higher chance of that bone never growing into the knee replacement, meaning that it's loose, and then that would cause continued pain. So in any osteoporotic or osteopenic patient, my choice is to always use a cemented knee replacement. So we have a few questions here on activity after a knee replacement. So can you do steps immediately after total knee replacement? Yes. I have you up and walking that same day. Most patients actually do go home that same day. The biggest thing after you go home is to still walk around the house, but to take it easy. I don't want you walking around the block or trying to go to the grocery store and walking all around the grocery store, or trying to get 0 to 120 degrees of range of motion. So you can take steps, your weight bearing on it right away, and that's no issue. But I just have patients listen to their body, because if you're in too much pain, that's your body telling you to slow down. And the reason you're in pain immediately after a knee replacement is because of swelling. So we prescribe anti-inflammatories, we prescribe narcotic pain medicine for the beginning, and that all helps that. So in short, yes, I want you taking steps after, but I don't want you doing too much. Elliptical after total knee replacement. That's one of the best things you could do. Elliptical and stationary bike, they're both low impact. It's easy on the knees. It's good exercise. Patients love it. So I highly recommend the elliptical after a total knee replacement. The life of a total knee replacement. Great question. So, as we have more and more advancements in technology, the life of the knee replacements, it's improving. So the plastic piece that we make now, it's completely different than the plastic piece we made 15 years ago, 20 years ago. And the knee replacement keeps getting better. It keeps getting made of better materials. And the life of knee replacements, it should last at least 30 years if it's done correctly. So it does last a long time. And I tell most people, younger patients, they're obviously at an increased chance of a revision. However, our older patients, 50, 60, this should hopefully last you the rest of your life. How do you feel about getting steroid injections over many years, 15 to 20 years, as long as they still provide relief? I think if non-operative management is still working, you continue non-operative management until it no longer works. So steroids, medications, gel injections, if it's still working, keep going for it. Some people are concerned about systemic absorption of the steroids in the knee. It's very minimal. Like I said, the biggest complication you see after a steroid injection is in patients with diabetes. They might have increased blood sugar. And even in patients with diabetes, it's very low percentage. It's less than 2-3% that will have an increase in blood sugar. So it's pretty rare. Okay, it does happen, but if steroids are working, then you definitely for it. How often do you have problems with scar tissue? I thought polyethylene was toxic. Is that what you said for the plastic? So, great question. So for the polyethylene part of this question, so the type of polyethylene used in knee replacements, it's called highly cross-linked polyethylene. And what that means, it's basically made in a lab, and the highly cross-linked part makes it really adverse to wear. So polyethylene, if it's worn down and you have little fragments floating around the knee, then that can cause reactions that will lead to pain and a local toxicity. That being said, 15 to 20 years ago, this highly cross-linked polyethylene was introduced, and that was probably the biggest game changer in hip and knee replacements. This allowed the knee replacements and hip replacements to not only last 15 to 20 years, but 30 years or more because of this really, really well-made polyethylene. So with the new replacements on the market, you don't have to worry about that. And then how often do you have problems with scar tissue? So scar tissue is going to form no matter what type of surgery you have. And scar tissue for a knee replacement is going to happen. That being said, we make sure that you're in appropriate range of motion in the operating room, where if scar tissue forms, you still have very good range of motion postoperatively. So the scar tissue is actually part of the healing process. So it's actually a good thing. It'll make the knee feel more functional. It won't be loose. It can be a problem in patients who tend to form more scar tissue. So in patients that have a history of, hypertrophic scars or keloids, I do keep a closer eye on these patients. I'll see them more often over the first 3 months because if increased scar tissue does form, we can do kind of a manipulation where we bend the knee back and forth in the operating room to break up that scar tissue to allow you to have range of motion. So it is a complication that could happen with knee replacement surgery. It's pretty rare, it's less than 5%, but it does happen. So in patients who might be more prone to scar tissue, orthopedic surgeons should keep a closer eye on them, and we can address it early on if that does happen. The only exercise I like to do is dance. Can I do that? Is that high impact? So, a big reason for a knee replacement, you want to get back to what you like to do. You want to live your life, get back to doing the things that keep you happy and healthy. So, yeah, dance could be slightly higher impact than cycling or an elliptical, but can you do it? 100%. You should live your life and not worry about it. And once again, with the quality of the plastic and the metal that we have now, these knee replacements are lasting a very, very long time. Are leg extension exercises with not too much weight a good idea? Yes, it's not just a good idea, it's actually a great idea. I have a lot of patients that they go to the gym, they don't want to go to physical therapy. I demonstrate with them every time the knee extension exercises. Do low weight, high reps that really works your quad muscles. And that's probably the most important muscle to help take pressure off your knee joint. Cortisone versus gel injections. So, cortisone is my go-to. All the research, it points towards cortisone shots, and that's a steroid shot. That will give you the best pain relief. When that eventually will fail, because it often does, and that's after many, many times of steroid injections, for patients that are not operative candidates, or if they would like to avoid surgery, then we can try gel injections. There's not as much supporting research for gel injections. I usually say it's a 50-50 shot, but it's definitely worth the try for patients who don't want to have surgery or for medical reasons they can't have surgery. It has very little downside. After knee replacement, can I ride my horse again? Once again, definitely. That's you can definitely go to that. Obviously, be careful not to fall, but otherwise there's no issues with horseback riding. What's the best exercise machine to use for in-home aerobic exercise? Treadmill, elliptical, stationary bike, or other? Stationary bike's my go-to because not only is it no impact, you're not pounding your knee on a surface, you're not putting extra weight on your knee, but it's also helping with your range of motion. Think about all the flexion you get in your knee when you go a full revolution around a stationary bike. That's by far the best. Elliptical, I would say, would be the second best. And then treadmill's great too. I wouldn't necessarily run if you have bad arthritis because that's a high impact exercise, but walking's great. And to be honest, any exercise you do for your body is going to help. Can a full knee replacement be done that also preserves all ligaments? So this is a good question. So we always preserve the inside and the outside ligament. That's your MCL and your LCL. And then there's different options with your ACL or PCL. A lot of surgeons will keep the PCL, and that's your posterior stabilizing ligament. Most surgeons, they will take the ACL. That's kind of how the best working knee replacements are performed. You take the ACL. There are knee replacements that you don't have to take the ACL or PCL. They just do not have as good of a track record as the knee replacements where you do take the ACL. It's much more reliable to do that. I have had a total knee replacement and a revision, and now my revision is coming loose. What's my option now? So, in addition to primary knee and hip replacements, I perform a lot of revisions here, and I see a lot of knee replacements from elsewhere that have worked for many years and then often have a problem. Loosening is one of the more common problems that I do see after knee replacements. What's the option? So, it's really a revision knee replacement, taking what's in there out now. And there's different methods to try to prevent this from ever loosening again. So using something called cemented stems to get better fixation in your shin and thigh bone. There's advancements in technology, things called cones, which basically act as the metaphyseal part of your bone. So that's kind of the top part of your bone to improve your fixation. So loosening does occur. However, when it does occur and you need a revision, there are many ways to treat this and to try to make sure that the loosening does not happen ever again. What about cartilage transplants? So cartilage transplants are procedures that most sports surgeons do perform. And it's very good and has great results if there's a very small local defect. So if you had a sport injury and you have a small chondral defect, it does not work if you have widespread arthritis. So little chondral cartilage defects it does work for arthritis it does not.
Dr. Kugelman, there's a few questions, and somebody had emailed about this too. So can I just ask that?
Please.
Is there any age beyond which knee replacement surgery is not a viable option, or at least when alternatives should be considered? If so, what age is that?
Great question. I do not go by age at all. You can get a knee replacement in your 80s. You can get a hip replacement in your 80s, knee replacement or hip replacement in your 90s. That's completely fine. It's really about your health, your cardiac health, your pulmonary health, the status that you're in from a medical standpoint. If if you're getting older, obviously there could be more medical problems if you have any medical issues. So as we get older, we develop more medical issues. But if you're a relatively healthy 80-year-old or 90-year-old, there's no problem. And a lot of people, they'll say, I have arthritis. I'm in 4 out of 10 pain. I'm in my late 70s. Should we just do this now? If you can still function and live your life, there's no reason that you can't keep living your life with your natural knee. And then once it gets really bad where you can't walk anymore, and you're in your 80s and you're still healthy, then you can perform a knee replacement with no issue. Even the 80-year-olds, 90-year-olds, most of those patients go home as well. Rehab's an option, especially if you live alone and things like that. But most patients, even in their 80s and 90s, they will go home. It's a great question for everyone asking that one.
Thank you.
Can I go to physical therapist for an exercise program after a total knee replacement in addition to a home program? Yeah. So at 2 weeks, I give everyone a physical therapy script. I think it's better for you to get out of your house. There's more machines and there's more modalities that the physical therapist can use for you in the office. So I always recommend an outpatient physical therapy prescription. I say about 2 to 3 times a week for physical therapy in person. However, you should still do the exercises they teach you the other, 2 working days a week. So I say treat it like a 5-day work week as far as knee exercises go, and you can give yourself a few days off here and there. Usually, I'll say do that for about 6 weeks until you're happy with your range of motion, and then strength will just keep coming back as you're doing more and walking around. Complex torn meniscus. So a torn meniscus, if there's no arthritis, it can get treated with an arthroscopy type of procedure, whether it's a repair, there's different types of meniscus tears. Some can be repaired, some just have to be debrided and partially taken out. But if you have a torn meniscus with no arthritis, then a knee arthroscopy is an option. If you have bad arthritis, that means you're going to automatically have a torn meniscus. And if you do any sort of knee arthroscopy when you already have bad arthritis, it's likely not going to work. So at that point, if you have both a torn meniscus and knee arthritis, you're looking at a knee replacement. After a knee replacement, will you get full movement of the knee again? The biggest predictor of your knee range of motion post-operatively is preoperative range of motion. So if your range of motion is 0 to 90 preoperatively, you'll have around 90, 95, maybe 100 knee range of motion. If you have full knee range of motion preoperatively, you'll have full range of motion postoperatively. And the reason for that is stiffness is mostly because of soft tissue contractures and scarring. And you can only release so much soft tissues without doing too much damage. So, if you have good range of motion before knee replacement, you'll have good range of motion after. If your knee range of motion is not as great, it'll likely be better after, but it won't be, you won't go from 90 degrees of range of motion preoperatively to 140 postoperatively, but it will be better.
Dr. Kugelman, there's also a few questions about doing both knees at the same time. Do you recommend that? Do you do that? And then if you do need both knees done, if you don't do them at the same time, if you need both done, how long in between getting one done can you get the other?
Great question. So this is commonly asked because about 40 to 50% of people they'll have knee arthritis in both their knees. So I personally recommend staging it. And that means doing one knee replacement now, and then the next one I would do at 3 months when you're pretty much 90% healed. The reason I recommend that is because, once again, all the research shows significant more complications, including blood loss and, delayed function if you have both done at the same time. People do perform both at the same time. I just personally rather take less complications and just have you wait about 3 months. What I often do for patients that have bilateral knee arthritis, we'll do one knee and then we'll give you a steroid shot in the other knee in the operating room. And in this way, it could help you for that 6 weeks to 3 months while you're waiting for that next knee replacement. But I'll stage it about 3 months apart. I have pseudo gout in my knee. What should I do for this? So pseudo gout, that basically it's crystal deposition. It's similar to gout. It's just a different type of crystal. And if you have arthritis at the same time, we would still kind of treat it like arthritis, injections, medications, and knee replacement. For patients that have gout or pseudo gout without arthritis, I'll often refer you to a rheumatologist because there are some medications that they have up their pockets that can help decrease the crystal formation that's kind of outside of the orthopedic surgery perspective. You said a partial knee replacement preserves the ligaments compared to a total knee replacement. Can you talk more about how that affects you later on? So, great question. So, in a partial knee replacement, the only thing you're taking out besides bone is that compartment's meniscus. Otherwise, the MCL's there, the LCL's there, the ACL's there, PCL's still there. And when you have all your ligaments with a partial knee replacement, it feels like a more natural knee. Later on, you could, of course, tear your ACL. You can tear your PCL. This may affect the partial knee replacement a bit. However, it's pretty uncommon if you don't have a torn ACL and you have a partial knee replacement to tear it later on. So usually, you'll be good unless you develop arthritis in the other compartments. That's the big thing to worry about with the partial knee replacement if you develop arthritis in the other compartments. So that's why I'll only perform a partial knee replacement if it's only one compartment that's mainly affected. Natalie, do you have any more questions?
I do have a couple that I see are similar about the brand of knee replacement parts that we use, and I know um there's several. So if you want to touch on that.
Yeah. So there's a bunch of big companies. There's a bunch of small companies. It's really surgeon preference, and everyone has their opinion on what the best knee replacement is. They're all pretty much the same outcomes. So as long as you're doing one of the more recent knee replacements on the market, the ones that have that highly cross-link polyethylene I talked about, they're all the same outcomes. There's not one that's better than the other. Technology has gone a long, long way. So they're making them last longer. These companies are making them feel more like a normal knee. So there's pretty much no difference with that. Same with robotics. Robotics is definitely a hot topic, and the outcomes for robotics. Some patients really want robotic surgery, and that's fine. But the outcomes, it's pretty much the same outcomes where if you have a robotic versus a manual knee replacement, meaning no robotics, your patients, they do the same.
Yeah, that was actually one that I saw a couple times too about robotics. Another one is how long is a typical knee replacement surgery? How long does the operation take?
Good question. So it depends if it's cementless or cemented. It's about, 45 minutes to an hour and then stitching everything back together. So you're pretty much back there for an hour and a half. And cemented, it takes about 15 minutes longer because you need the cement to harden. So I would say, from the time surgery starts to the time you're leaving the operating room, it's about an hour and 10 minutes to an hour and a half.
Okay, thank you.
Yep, of course.
There is one good question. Someone said that they have a nickel allergy, and are there any knee replacements that don't contain any nickel for those who are allergic?
Yes, great question. Very rare to have that, but people do have that. And there are knee replacements that we will use if you have a nickel allergy. So most knee replacements do have some sort of nickel in it, but there are ones we will use if you have specific metal allergies. So that's a great question. There are options for that.
Okay, great. I know there were you answered a lot of questions, so thank you so much, and thank you for that informative presentation. We apologize if we could not get to your questions. Tried the best we could in the time that we had for the hour this evening. Thank you all again for joining. You do all have my email, so please, if you're interested in making an appointment, I'm happy to help facilitate that, answer any questions as best I can. We did record this. We will be sending it out by the end of the week. It will also be on our YouTube channel and on our website. So thank you again, Dr. Kugelman. We appreciate your time
Thanks
and
for
for
having me, and thanks everyone
educating.
for joining.
Thank you so much. Everyone have a great night.
Take care.